Yes, thank you very much. And thank you to Phonak who sponsored this presentation. And my name is Hashir, and I work in the Royal Surrey County Hospital in Guildford. And I want to share some of the clinical research that we've done in the Tinnitus and Hyperacusis clinic in Guildford with you. And obviously I only have 20 minutes, so I won't be able to share all of the studies, and so I'm going to focus on one of them, which I thought are going to be very relevant to audiologists. Is about avoiding discomfort when you're doing a hearing test or uncomfortable loudness levels for people with tinnitus or hyperacusis. However, we have asked International Journal of Audiology to create this special collection of the clinical research papers that we published in IJA in this one special issue. And so this is the full text of all of the research studies on tinnitus, hyperacusis, real ear measurements, as well as motivational interviewing, all done in Guildford. So if you want to have the free copy of this, please visit our stand number 56 in the exhibition hall for the Royal Surrey. Everyone can have one. This is my tinnitus team. The 5 people who see tinnitus patients, and in our clinic most of the work is focused on a specialist version of cognitive behavior therapy for management of the distress, which is linked to hyperacusis or tinnitus. And a couple of the people in the picture, Gemma and Jennifer, they're actually here in our Royal Surrey stand. So if you wanted to specialize in tinnitus and you wanted to understand how does it feel like to see tinnitus patients every day and providing cognitive behavior therapy for them, do go and have a chat with them. I'm happy they're sharing, they'd be happy to share their experience with you. Just by raise of hand, I just want to see whether how relevant my talk is going to be to the audience. So how many of you actually see patients who may have tinnitus and hyperacusis? That's excellent, so that's very relevant then. And so in the studies that we have done, they've been in collaboration with different people, and Professor Brian Moore from University of Cambridge, Professor Richard Salvi in University at Buffalo, Professor Ali Danish from Florida Atlantic University. Karen is the head of the audiology department. Professor Bertold Languth from Germany, and Dr. Michael Landgrebe. These 2 guys are psychiatrists, and to the elements that our research were relevant to mental health of people with tinnitus and hyperacusis, they offered a lot of input. And the top 3 people are hearing scientists and audiologists, and they supported us in those aspects of it. And Don McFerrin, who is an ENT surgeon, he also helped us in one of the studies on tinnitus and hyperacusis in children. So this particular study that I want to talk about is, the idea of it came to my mind when I was doing a hearing test for a patient who was referred to us for tinnitus. And so I was doing the hearing test to measure the threshold of hearing, and very close to threshold of hearing, whenever he was pressing the button for the faintest noises that he could possibly hear, he was flinching, giving me this face, and I was like a bit unsure. Why is it that a sound that is supposed to be the faintest sound that he can possibly hear, it's giving him this reflex? He obviously found them uncomfortable. So this was the hearing test audiogram of the person, and up to this point, and we were following the British Society of Audiology recommended guideline in doing pure tone audiometry. So just to recap on the guideline itself. So if you test 1000 hertz and the hearing threshold is at 10 decibel, and you move on to test 2000 hertz, what is the initial presentation level that you should start? At 2K? I'm sure you know. So if 1K is 10 decibel, now you want to test 2K, what is the first intensity of sound that you present the sound according to the BSA guideline? 40. So it's 30 dB, thank you. 30 dB plus the 10, so that would be your starting point in 2000 hertz, and the same in other frequencies. So the recommendation guideline, the previous version, used to be you add 20 decibel to the previous frequency, but the newer version is 30 decibel to the previous frequency. Now, if you have, say, 4000 hertz is 55, what would be the presentation level at 8000 hertz? 80, because they say don't go above 80 as well. And so this patient's hearing was like this. And then when I did the ULLs for the person, they were here. So even if I presented the 8000 hertz at 60 decibel, still would have exceeded his ULL, and in an attempt to find actually his lowest, his hearing threshold. So the question was, and his other ear was even worse. Some of the ULLs were completely overlapping with his threshold of hearing. How many of you actually do ULLs for the patients? So just a recap on how do we do the ULLs. The method that we use is to put the headphones on the ear of the patient and tell them that the noises are gradually getting louder. You need to press the button as soon as you think it's uncomfortable. We also tell them this is not a test of tolerance, so we are not testing how brave you are. We just want to know when the noises become uncomfortable. So press the button as soon as you don't like it. And so that's the instruction that we give them. And the levels increases in 5 dB steps, and then they press the button as soon as they don't like it. So based on this patient, in some of the frequencies, the initial presentation level, if you were going to follow the BSA guideline and add that 30 decibel, that initial presentation level would exceed his ULLs and will cause discomfort for the patient during a hearing test. So the question in my mind was, how many of our patients could actually have this problem? What would be the percentage of the patient for whom, if I do a hearing test following the BSA recommended protocol, the initial presentation level of the pure tones will exceed the ULLs, at least in one frequency in one ear? So that was the question. And we were in a good position because we had lots of hearing tests, which we have done for people with tinnitus, and we had lots of ULLs that we have done for the same people. And we also had a wide range of questionnaires, which we gave to the patients to complete during their appointment. So it could give us some idea about what is the percentage, what is the likelihood of this to happen, and what are the factors that contribute to this risk of discomfort during PTA, and what to do next. So here is the title of this study, Incidence of Discomfort During PTA and Measurements of ULLs Among People Seeking Help for Tinnitus and/or Hyperacusis. So we didn't only calculate what happens when we do PTA. We also calculated what happens if we do ULLs for them based on the BSA protocol. How many people, the first tone that you present to measure the ULL would actually exceed the ULL levels, causing a discomfort in them. So 362, the data from 362 people, it was a cohort of the patients, the 1 year period we included to this. And so the criteria for discomfort during PTA was said to be this. Experience of discomfort during PTA was considered to be present when a tone with frequency F presented as at 30 dB above the threshold for an adjacent frequency exceeded the ULL for frequency F for at least one of the measured frequencies. We took that as, yes, discomfort was present in this particular person. And for the ULLs, the experience of discomfort during measurement of ULLs was considered to be present if a starting level of 60 dB, which is what is recommended by BSA, exceeded the patient's ULLs for at least one of the measured frequencies. That's what we called as experience of discomfort during PTA and ULS. So far, do you have any questions before I move on to the results?
We have one on Slido.
Okay.
If you've got to answer it now at the end. Do you test all your patients' ULLs?
Yes. And however, this is the data collected from a specialized tinnitus and hyperacusis clinic. So patients who we see are patients who are particularly referred to receive therapy and support with regard to their tinnitus and hyperacusis. We don't routinely test ULLs in other clinics. The data is only relevant to our tinnitus and hyperacusis clinic. Good question. Anybody else have any question on this so far? Good to go? Yes. Okay, before I move on to the next slide. So what is your guess? What was the percentage of the people who come to a tinnitus clinic, not the normal audiology clinics, to a tinnitus clinic, and if you do a hearing test for them based on the BSA protocol, at least at one frequency, their initial presenting level will exceed their ULLs. What is the percentage of this to happen? Make a guess. 1%? 5%? 21, yeah. You're cheating. You say, are these slides are accessible? I didn't know that. So yes, 21%. And this is quite a big percentage of people who could experience this problem, and which is quite important because in all of the clinics is important, but the tinnitus clinic, when you want to build a relationship with the patient and provide a therapy for them and help them to manage their tinnitus better, if your first intervention of a hearing test causes discomfort in them, it can kind of damage that relationship and the trust that they may have in you. Also, and then we calculated, what if we make some changes in the initial presentation? What if we modify the BSA recommendation of 30, turn it to 20, 10 hearing thresholds? How much this risk of discomfort would reduce? So the incidence of discomfort would reduce to 10%, 2.7%, and less than 1% of patients if the starting levels had been 20 dB above, 10 dB above, or at the same level as the threshold for the adjacent frequency. So in order to get this 21% risk of discomfort in those patients, if you want to get that down to less than 1%, you effectively need to present at the same level as the previous frequency. There have been studies in the past that if you do this, would this actually make any difference in the actual final threshold of hearing that you find? And the result shows doesn't actually make any difference in the final hearing threshold. So your hearing threshold measurement is still being accurate. It may slightly take longer in terms of your hearing test, because there may be periods of silence that they are not hearing anything, up to the point that you actually raise the volume loud enough for them to start pressing the button. And for the ULLs, 24%. If you start the ULLs at 60 decibel, then for 24% of the patient, that 60 decibel is more than their ULL threshold. So they will feel discomfort right away. And this incidence of discomfort would reduce to 3.6% of patients if the starting level reduced to 30 decibel, and to less than 1% if the starting level will reduce to 15 decibel. What we do in our clinic, we usually start the ULLs from the threshold of hearing. So we know that at least the starting level cannot cause any discomfort on the patient. And then we had lots of questionnaires. All of the patients who come to the tinnitus clinic, they complete a wide range of questionnaires. Some of them are directly related to their tinnitus and hyperacusis, some of them to the relevant symptoms, like insomnia, anxiety, depression, and things like that. So, and if there is a question that you give these questionnaires to all of those patients, the answer is yes. We give these questions to all of the patients who come to the tinnitus and hyperacusis clinic. So, because we have those questionnaires, we could analyze who are the people in higher risk for this discomfort during the hearing test to happen for them. And people who had abnormal score on an anxiety questionnaire were more likely to experience discomfort during the PTA. And of course, those who had higher scores on a hyperacusis questionnaire were more likely to experience that problem. So what about other tests? The mean level, sound level at the eardrum produced by a 512 Hz tuning fork when conducting a RINA test is about 90 dB SPL. Acoustic reflexes usually exceed some of the ULLs. The probe tone of the tympanometry could exceed that. The 10 test of the threshold equalizing noise can exceed that. Sound levels in the MRI scans can exceed that. So this is not just a pure tone audiometry. So lots of other different tests can also exceed people's ULLs when they have this particular problem. In fact, this patient that came to my clinic, he said the ENT doctor who saw him, he used a tuning fork to do a test, and that triggered his tinnitus. And but I can now understand that he was actually feeling discomfort when he listened to that tuning curve because his ULLs were highly reduced. So the idea was that a balance must be struck between the cost of causing discomfort to patients and the benefit for clinical management. And if deemed appropriate, needed to do these tests, they need to be properly counseled about the reasons and what is it to expect. And what you can do on Monday, begin with a level of 0 decibel, starting frequency of 1 kilohertz, and to set the level for the subsequent frequencies to be equal to the level at the threshold for the previously tested frequency if you are doing a hearing test for patients with tinnitus and hyperacusis. And for measurements of ULLs for people seeking help for tinnitus and hyperacusis, we recommend the starting level of equal to measured audiometric threshold at the test frequency. Also, there is really no need to go above 80 decibel. If they don't press the button at 80 decibel, you can mark it as unreached in terms of their ULLs. Because if they do have hyperacusis, their thresholds of ULLs will be much less than that. So above 80 dB really doesn't need. 2 questions. Do I have 2 questions?
Yeah.
Okay.
Okay, because we're at the end of the session now. So we've got two. Is the ULL less than 30 dB above the adjacent frequency in normal hearing people?
Pardon?
Is the ULL less than 30 dB above the adjacent frequency in normal hearing people?
ULL of less than 30 dB, do you mean that, well, a ULL of less than 30 dB does exist, and we call that severe hyperacusis, but it is very rare. It's about 4% of the patients who come to our clinics have this particular problem.
Okay. The second question was, given poor reliability of ULLs, high subjectivity as well as bias and lack of control data, how reliable is this finding? No ULLs, no discomfort.
Well, ULLs are reliable enough. There have been lots of testing showing that their retest reliability. The problem with ULLs is that whether they are actually pinpointing hyperacusis. And that remains to be a question for further research. But all I report here is that in 21% of the patients, if you follow the BSA guideline in the way that we said, for 21%, the initial presentation level of your pure tone would exceed their ULLs. And we can only say this. And the final slide is, this is my tinnitus and hyperacusis masterclass, which I teach methods of therapy for those who are keen to specialize in the subject.
Okay, thank you very much.